Hi guys, my name is Melanie. I'm going to talk to you about Kawasaki disease today. So let's get started. Oh, let me share my screen first. I always forget to do that. And start. So Kawasaki disease. Kawasaki disease, or KD as it'll be referred to a lot in this PowerPoint, is an acute febrile disease, which is characterized by systemic vasculitis. So basically, vasculitis means swelling of your blood vessels, and that's going to occur all over your body. And acute, in this case, means it's self-limiting. It sort of starts and then wraps itself up in a set amount of time. It's not chronic. And it's characterized by 5 main symptoms and a moderate to high grade remittent fever. So that's where the febrile comes in. And it severely impacts the coronary arteries. So it's the actual leading cause of acquired heart disease in children in developed countries, specifically Japan and the United States. So what causes Kawasaki disease? We have no clue. Upwards of, I'd say, 4 decades of research, and we have no idea what causes it, but we do know some things, such as that it has a seasonality, and it occurs more in winter to early spring. We also do see some regional epidemics that have a clear epicenter, and we have some theories of what triggers it. We've gone through pretty much every pathogen in the book. It could be a bacterial toxin or an unknown pathogen altogether, like a virus. Or some studies suggest environmental causes, like a windborne agent, or even residing near a standing body of water has been shown to have an effect. And data suggests that probably it is some sort of infectious agent. It's not genetic born, or it's not some sort of syndrome, although host genetics do play a role, and we'll get into that more later. And while it is important to determine the cause, especially in terms of maybe treatment or pathophys, getting more into that, some researchers are actually looking more into developing a clear diagnostic test, especially because time is so important when it comes to this diagnosis, because KD has a really big effect on the heart, and obviously that's bad. So we want to maybe speed up the diagnostic process a little bit. So who gets it? Mostly we're seeing it in children under the age of 5. 80 to 80% of the cases are that group, and it is 1.5 times more common in males. So basically, where there are children, there is KD, kind of grim, but that's what we're seeing. And it can occur in young adults and very, very rarely in adults, but it's much less frequent. But we have seen it in adults later down the line. And KD does affect all races, and we have seen it in all races, but it's very overrepresented in Asian populations, specifically East Asian populations, which suggests a genetic or cultural predisposition. And actually, studies have shown that KD risk for a sibling of an individual that has KD is higher than that of someone in, say, just the general population. And KD is actually the most common in Japan. Numbers show as of 2016, KD affected 309 out of every 100,000 children. And then the US has the second highest rate of incidence, with about 9 to 20 every 100,000 children, according to the CDC. And actually, California and Hawaii, which are 2 states with high Asian American Pacific Islander populations, have a much higher KD rate than the national average, which suggests, again, a genetic or cultural predisposition, seeing as it affects East Asians a lot more than it does other races. So symptoms, how do we know who gets it? So there are, let me move my camera just so you guys can see this little graphic. I don't even know if that helps. Anyway, there are 5 main symptoms used for diagnosis. There is a rash, which usually starts in the trunk and then sort of spreads all over the body. There is conjunctivitis, which means red eyes. So usually you're going to see the redness towards the edges of the sclera and not really around the iris. So conjunctivitis of the eyes, but only towards the edges. And then another symptom is cracked, really red cracked lips, and then what's called a strawberry tongue. So the tongue, what happens is like the top layer of cells sort of sloughs off. And then what sort of remains is a really red tongue with very pronounced taste buds and like little buds, which looks like a strawberry. So they call it strawberry tongue. Kind of gross. You're also going to get swollen lymph nodes, very specifically in the neck, your cervical region, and then redness and swelling of the extremities that will eventually lead to desquamation, which is the skin starts to peel off. Again, gross. And then doctors will also typically look for a fever that's present for 5 days or more Even without the rest of the symptoms, a 5-day or more fever in a child should be instant alarm bells for, let's maybe look into KD, why not? So again, diagnostic criteria for a complete diagnosis of KD, 5-day plus fever, and then 4 out of 5 of these symptoms right here. So diagnosis. Complete Kawasaki is usually, again, diagnosed by 4 out of 5 criteria and a 5-day plus fever. However, a lot of these criteria occur at different stages, and they can even occur like one after the other, not occurring at the same time. So it can be difficult to get a full diagnosis right away, which is a problem because a quick diagnosis is very imperative, as there's a very short treatment window before irreversible heart damage occurs. So if a child will lack the criteria for a complete diagnosis, but they'll still exhibit some of the signs, it's pretty often considered a incomplete KD, and it can be confirmed through further testing. So typically an EKG or an echocardiogram will be taken regardless, even if you do have a diagnosis, because we really want to take a look at what's going on in your heart due to KD's effect on the coronary arteries. We want to see what's going on there. And then lab work will also typically show an elevated white blood cell count, especially with neutrophil predominance. Why? So evaluation of the suspected incomplete Kawasaki disease. So here's just a graph. This is from, or a chart. This is from the American Heart Association. It tells you sort of what to look for if the child isn't quite exhibiting all the symptoms, their fever didn't go on 4 or 5 days, or they don't have as much of the criteria. So we'll get some lab work in, and CRP and ESR, which are down here. That is C-reactive protein and erythrocyte sedimentation. And those are both signs of inflammation in the blood vessels, which is what's going on in Kawasaki. And then we'll look at other lab findings: anemia, white blood cell count, urine, platelet count, or even just a positive echocardiogram. We're going to start treating. So pathophys, how does this start? Again, we don't know. We know sort of when it starts to kick off, but we don't know what starts that process. Some pathogen invades somehow either the respiratory or the digestive tract, but it does start to get processed at the local lymph node, and then B cells at that lymph node start to differentiate into immunoglobulin A plasma cells. Those play a big role in inflammation, and those will start to spread throughout the body along with neutrophils and other immune system cells. So more B cells, T cells, monocytes, macrophages, those are all starting to spread throughout the body. The immune system's alarm bells are going off for something. We don't know what it is, but it is kicking off. So they're going to start to travel to the coronary artery, and inflammation of the coronary artery, we start to see that about 6 to 8 days after the KD onsets. And after about 10 days, that is sort of the window to where we start treatment to avoid irreversible heart disease. That's a 10-day window. We're going to start to see lymphocytes, which are B and T cells, and macrophages infiltrating the arterial wall, causing structural damage and dilation. So that means that the arterial wall, it's going to start to get bigger, but the wall is going to start to get weak. So it's going to start to expand, but the wall is getting a lot weaker, which is bad news. So all of these cells are activating a cytokine storm, and they're telling the endothelial cells in the blood, endothelial cells in the blood vessels to express adhesion molecules. And then all of these immune system cells are going to start to stick to the walls of the blood vessel, and they're going to start to damage it. Molecules of note, these are cytokines, are TNF alpha and IL-1. TNF alpha is tumor necrosis factor. That's a factor that if you have a tumor, it's going to start to tell cells to kill themselves, because obviously you don't want a tumor. But if this is just a random arterial wall cell trying to keep your blood in, especially the blood that goes to the heart, we don't want the cells killing themselves. That's bad news. So this is really bad news for your arterial walls. And then IL-1, that is another pathway that starts to get cytokines into your blood, and that's going to, or into your arterial walls. That's going to let more TNF alpha cells in. Bad recipe for disaster. So after about 12 days, this is all happening. You're necrosing the walls of the artery. It's being attacked by your immune system, and they're starting to get weaker, weak enough for aneurysms to develop. So those are big bulges in the arterial walls, and that can lead to thrombosis and clotting. So once there are these weird abnormally shaped bulges, like platelets and clotting factors can start to stick to those and form a thrombus, which is basically a clot that's stuck in your artery. And that's bad news. We don't want that because that can lead to heart attacks. Not good. So after about 25 days, this is without treatment, the inflammatory cells start to peter off very slowly. And by day 40, they're almost completely gone. However, the heart is now really, really weak and at risk for heart attacks and swelling of the heart muscle, which can lead to more damage. Even if you don't get a coronary aneurysm, you're still at risk for these things, which is why treatment is so, so important. So here's just some diagrams of what's happening, sort of what I just described. So here is a normal coronary artery. Here you start to sort of get the neutrophils in here. They're usually the first to enter. And then once you get the neutrophils in here, you see it's started to dilate. It's much bigger than it is here. And we have all of these immune system cells, IgA plasma cells, macrophages, T cells, all these things. And then again, we see members of the immune system building up on the arterial walls. And in the difference between these muscle cells and these muscle cells, they're much more spread out, which means that the wall is a lot weaker because now there's a bunch of little micro abrasions in the muscles and they're like tearing. So here's a little bit closer look at that. We have the inflammatory stimulus and all of these cells are here. This is what a normal arterial wall should look like. But now over here, we have all of these interleukin cells. And then here we go, here's tumor necrosis factor. Here's IgA plasma cells causing swelling. And again, all these muscular microabrasions, which triggers more immune system response, which triggers more swelling and microabrasions. And then you get an aneurysm. So yeah, we really want to put a stop to this as soon as possible. We want to get that diagnosis as soon as possible. So here's some real life examples. This is someone's coronary artery. You'll notice that this is what it looks like originally. And then this is an aneurysm. These are several little aneurysms along the, well, these are little, these ones are big aneurysms along the coronary artery. Obviously it shouldn't look like that. That's very bad. This could easily lead to a thrombus, which could then cause a heart attack. And then here is your left anterior descending coronary artery. Again, very bad. Here's another big aneurysm. You can sort of see the outline of the heart right here. And then here is a slide of both an epicardial coronary vein and an epicardial coronary artery. This is from an autopsy of a deceased patient. Unfortunately, they did pass away due to complications of Kawasaki. And here you can see that the vein did have experienced some wall thickening, but nothing too bad. There's still blood. Look at how open this space is. It's obviously can still pass blood through it. And then here is the artery. This is what is left of the opening. It has swollen so big. The lumen of the artery has tried to overcompensate for the stretching of the walls, and blood couldn't get through, which caused a heart attack, unfortunately. So here's just another look at aneurysm formation. Again, the wall starts to stretch and either the clotting material will start to layer on the wall and start to return it to normal, or even the lumen of the artery will start to sort of distend and try and return the artery to normal, introduce some structure. It's still not as good, but it's better than nothing. Although this is sort of, the stenosis is sort of what happened back here. The lumen got too big and created a very small opening. And then the thrombus itself, a big mass, you can see right here, either it'll just become a permanent occlusion, usually in a blood vessel, it's not very important, or blood will find some way through it. But again, see how small these are in comparison to what the normal artery would look like. So treatment, how do we treat this? Again, it all stems back to the fact that we don't know what causes it, so we don't know quite how to treat it. So basically, there's nothing that we can just give you and your KD is cured or solved. So we really tailor the treatment specifically to the patient and their symptoms. The go-to right now that we usually give is a combination of intravenous immunoglobulin, or IVIG, and acetylsalicylic acid, ASA, or just aspirin. And IVIG has a generalized anti-inflammatory effect, which is really good. We want to sort of bring that swelling down so we can stop the dilation of the artery. And then when you combine it with intravenous immunoglobulin, acetylsalicylic acid is also anti-inflammatory and antiplatelet, which is good. That can help if there is an aneurysm there, that'll help reduce the risk of clotting. But one thing to look out for, ASA can cause Rye syndrome, which causes swelling in the liver and brain. Oh, that happens when you give aspirin to young children and infants. Unfortunately, it's either that or you at serious risk for a heart attack. So all you can really do is just monitor the patient as carefully as possible, make sure that they're on like recommended dosage, all that sort of thing. And also, while you are on ASA, the child should not receive the varicella vaccine or an active influenza vaccine, because that can also put them at risk for Reye syndrome as well. And then certain other therapies have been recommended. A lot of them are still in clinical trials, but two that we are using right now are corticosteroids, which help combat most forms of vasculitis. And then infliximab will bind up the cytokine TNF-A, which will stop it from secreting that tumor necrosing factor. However, about 10 to 20% of the KD patients will be termed IVIG resistant, and IVIG just won't work. So we need to treat them with other therapies. Again, a lot of these are still in clinical trials. This disease is relatively new, but ones that we're looking at are antibody therapy, plasma exchange, and cytotoxic agents. Cytotoxic agents, however, should be only really considered in the most severe of cases, because those can kind of kill off healthy cells as well. So if you are IVIG resistant, we'll usually just treat you with corticosteroids and infliximab. We'll use them just more often. And also cyclosporine is a calcineurin inhibitor. I'm sorry, I don't know how to pronounce that word very well, calcineurin inhibitor. But basically all that does is it really helps stabilize arterial wall inflammation, which is, again, good. We don't want that inflamed. And one promising method that we're actually looking at is a receptor to the IL-1 pathway, anakinra. So as of 2020, as of September 2020, I believe, this has only been tested in mouse models. It hasn't even started human trials yet. However, it inhibits the IL-1 pathway, which helps play a role in even the progression of Kawasaki, and it significantly reduced Kawasaki-induced myocardial inflammation and prevented further dysfunction and ventricular enlargement. So basically, it stopped both inflammation itself and it stopped further complications due to that inflammation. So here is a graph from the study. So they injected mice with LCWE, which is a bacterial factor that sort of mimics the symptoms and pathology of Kawasaki's disease. They injected that into mice, and then they gave them the IL-1RA, the anakinra factor. And so here are the results of the study. So here is mice without the IL-1RA, the anakinra factor. You can see that their arteries are, obviously there's stuff in them. They're all clogged up, and the walls are a lot thicker. This like darker purple area right here is the thickening of the arterial walls due to the inflammation. And they're so much thicker in this one. Even this one, which doesn't have a lot of clotting, the wall is still much thicker. But down here, the wall is a lot thinner, more composed, and there's barely any clotting at all. So the wall, see, it's so much thinner than the walls here. And then this one here, again, just thinner walls, not a lot of clotting. So it's very promising, and it works a lot faster than IVIG, which is why we're definitely trying to consider it. Again, we haven't started human trials yet, but it's something that we're looking into for Kawasaki, especially because Kawasaki disease cases are going up. I would hope that we're going to start ramping up research on this sort of thing. So aneurysms, how do you treat an aneurysm? Again, tailored to the patient, but other than a coronary artery aneurysm rupture, which is rare, the biggest threat you're going to see with an aneurysm is a clot, a thrombotic occlusion, because that can cause heart attack, which can cause death. So if thrombosis occurs, we're just going to try and give you whatever reestablishes your blood flow most rapidly. And usually we're just going to give thrombolytic agents, things that break up the thrombus TPA, tissue type plasminogen activator, that'll sort of activate that plasma right there and sort of try and break it up. And then we'll also give low dose ASA, which is really good for antiplatelet, and low dose heparin, which is an anticoagulant, again, lowers the clotting factor. And non-steroidal anti-inflammatories, ibuprofen, I can't remember the name of the other commercial one, but yeah, anything you would take for like a headache, joint pain, ibuprofen basically, and other related drugs, Tylenol, that's what I'm thinking of. Don't take those as they interfere with ASA, and they should not be taken during treatment because they will interfere. Obviously, that's bad. But I'm not going to go into all of this because this is from the American Heart Association's recommendations for doctors who are treating Kawasaki. But I just included this to give you guys sort of an idea of what goes on in this sort of treatment. And this is for aneurysms alone. This isn't even for Kawasaki as a whole. This is if you get an aneurysm, and there's so many different types of aneurysms you can get and the different types of situations you could be in, and then just whether or not it's recommended to give all of these different types of drugs. So again, just to emphasize that we really have to tailor this to the patient when it comes to things like this. So long-term management. Again, this disease is acute. It'll usually wrap up in about 4 to 6 weeks after you start getting a fever. So what happens after that? Your main goals, your heart is very weak right now. Your main goals are to prevent thrombosis and myocardial ischemia, heart attack. You're trying to keep your heart healthy. So virtually all death in patients with KD result afterwards from cardiac sequelae, which is heart complications after the fact. So patient monitoring is a must. And the level of counseling will really depend on the cardiovascular risk, like how badly did the disease progress? How many aneurysms do you have? Did those aneurysms have thrombosis, et cetera, et cetera. But typically, the average child will see a cardiologist maybe once or twice a year for a bit after, and then they'll consult with physical activity counselors just to see what they can and can't do. And usually age-appropriate reproductive counseling will be given as well, not because of maybe the genetic risk factors, but because of oral contraceptives and pregnancy. Both of those can obviously have an effect on your heart. Pregnancy, you're literally growing another person. And then obviously any new medicine, you should probably see how that affects your heart if you have some sort of heart disease. But yeah, history of the disease. I'll move my little thing again. So this disease is again, it's very new. It was first identified in the 1960s by Dr. Tomisaki Kawasaki, who is pictured right here very early on in his career. And he saw his first case in January of 1961. And actually, he was not a big researcher. He didn't work at a very big research institution. He was just kind of a local pediatrician, but he started seeing a lot of these cases in his area. And he's like, these don't really look like anything I've seen. So he kept a really good log of results. And in 1967, he published acute febrile mucocutaneous syndrome with lymphoid involvement with specific desquamation of the fingers and toes in children, clinical observations of 50 cases. So it was first published in Japanese, obviously, he's a Japanese doctor, but it was translated into English in 1974. And actually something really strange is around the same time, totally independently of each other, US hospitals in Hawaii were also documenting and reporting on Kawasaki disease. And we don't know why this happened because like they didn't consult at all. They just both identified it separately and at the same time. So that might have meant it started in Japan and spread through Hawaii, which again has a large Asian American Pacific Islander population. Maybe that's how it spread. But again, we don't know because we don't know what caused the disease. And the earliest cases have been retroactively diagnosed up until the 1950s. So we don't know whether or not cases existed before then, but they might have because, okay, Kawasaki disease is often misdiagnosed, or at least it was in the beginning. It shared symptoms with a lot of other diseases. And actually in the beginning, a lot of some doctors were bringing this to attention. They would say, why do our patients who have this one disease, mucocutaneous ocular syndrome, which is what was commonly misdiagnosed as, all our patients who we diagnose as this are dying or getting really bad heart complications, and we don't know why. And then they discovered Kawasaki disease, but it took a bit. And that could be another reason for its late discovery is because it shares symptoms, at least outward symptoms, with a lot of other diseases such as scarlet fever, measles, anything that gives you sort of like a rash all over. And it could have just hidden behind those other diseases and been misdiagnosed until we sort of got the technology to sort of look at things like your heart or even antibiotics, which allowed researchers and doctors to rule out other diseases during diagnosis. So Kawasaki has actually been in the news recently for COVID-19. COVID-19, we've actually seen in children and young adults a multi-system inflammatory syndrome, very similar to COVID-19. And it's actually been titled multi-system inflammatory syndrome in children, MISC. And it is distinct from Kawasaki disease. They're not the same disease, but they're very similar in symptoms. And a lot of researchers are wondering why. this could lead to misdiagnosis, but actually the more not exciting, I feel like exciting is a bad word, but interesting. The more interesting thing about this is that it can really help clue researchers in on maybe how KD started, whether or not it's airborne or contact transmitted. And actually, they did that because researchers in Japan, the entire nation was under quarantine, and it gave researchers a great test ground to see what would happen if you kept everyone inside for an extended period of time. And the study found that KD numbers did go down during lockdown. They decreased significantly, which suggests that maybe they were transmitted through some form of airborne pathogen. So that is a step in the direction of finding out what causes Kawasaki, which is really neat. So Kawasaki in the news. There's, other than the really recent development of COVID, actually Kawasaki isn't really in the news at all. Most of the news stories I found were from parent blogs or the foundation itself, the Kawasaki Disease Research Foundation in America, of just parents, mostly moms, sharing their stories about their kids and how they were, almost all of them were trying to raise awareness because this disease is new, and a lot of parents don't really know about it, and which is bad. It's not bad, but because of the treatment window is so short, and even if pediatricians aren't looking out for it, then you might not get a diagnosis in time, which can be the difference between a life-threatening heart complication and turning out just fine. So actually the doctors did an interview with a woman whose son had Kawasaki disease. And although it's kind of weird, it does raise some great points about raising awareness about Kawasaki and trusting your gut. Okay, I'm gonna stop it there because the rest of it is just talking about Rapid Lash. And when I first watched this, I don't know if they're sponsored by Rapid Lash or not. They didn't say anything about it in the YouTube video description. I just thought that was weird. But I mean, I guess good on them for raising money for Kawasaki awareness. But also something I thought was weird. This is a really weird thing to touch on. Why did they make the doctor sit in the audience when they could have just had him sit with all the rest of them? I was like, oh, maybe it was COVID, but this video was published in 2014. I don't know why he's sitting in the audience as opposed to with everyone else. That's weird. Anyway, but yeah, even though those two weird things, this video really does touch on a lot of good points. Pediatricians really should be looking out that 5-day fever, start to get Kawasaki in mind. I mean, I don't know if any of you guys are pediatricians, but maybe if you're going to be, keep that in mind. And then again, parents, a lot of the stories I read, parents were just, they had their kid and they had all these weird symptoms and they're like, what do we do? And they started to research and they started to say, hey, maybe my kid has this. And lo and behold, their kid had that. And they managed to do, they did manage, a lot of stories I read, they did manage to get treatment in time, but again, that 10-day window. So again, this is something that I think more awareness should be spread to, but again, not always. Anyway, here's my works cited page. But yeah, thank you guys so much for watching. Leave your comments below, or questions basically, and I'm going to look forward to answering them.